being able to communicate with you and exchange ideas today is really a privilege. Maybe unfortunately for you, what I'm going to try to do today is make you anxious and maybe even a little angry. But I hope it is for a good cause. The reason I want to make you anxious and angry is because I want you to make you uncomfortable so that you want to lead change. So hopefully I will make you a little bit anxious, but not as anxious that you will get demoralized and you don't want to make any changes, but rather that you get inspired to lead the change forward. So I'm going to divide my talk in two parts. One is what do we know? And then the second part, so not surprisingly, what is that we need to know? So we already know a fair amount of things. We know that treatment is not enough. We know a fair amount about risk factors for substance use disorders. We know a fair amount also about the course of disorders, and we have some knowledge about intervention efficacy. Now, in terms of knowing that prevention is necessary, we know that, as I was saying, treatment is not enough. So in this graph, you can see on the vertical axis, you can see the probability, the cumulative probability of seeking treatment for substance use disorders, and on the horizontal line, you can see how long it takes for people to get to treatment. And as you can see, on the vertical axis is constrained, it doesn't get to 50%. So it means that even after many, many years, not even 50% of individuals with substance use disorders get to treatment. You can see that this sort of plateaus at around 46%, even for substance use disorders, which are the most severe. So even less for substance abuse, even though that category doesn't exist anymore, but this is based on the DSM-4, and even less for alcohol abuse. And you can see that even after, if you look at the horizontal axis, even if after 30, 40 years, not even 50%. So we know that even if we were to increase access to treatment and quality of treatment, we would not get enough people into treatment to prevent the damages of substance use and substance use disorders. And also, I mean, it takes so long for many, many people to reach treatment, even when they do, that if we compare to any other disorder. So if you look at how many people, let's say, for instance, if we look at the 10-year mark, so less than, I mean, about 35% of people would seek treatment. Imagine if it took 10 years for people with breast cancer or people with diabetes or people with hypertension to seek treatment. We would see that, first of all, as unacceptable, and also the individuals who have those disorders would suffer enormously before getting to treatment. And yet, in a way, we have normalized that for individuals with substance use disorders, it doesn't really matter that it will take a long time to get to treatment, because eventually many of them will get into remission. So because treatment is not enough, we need prevention. I want to talk a little bit about risk factors, since we are going to think about prevention. And fortunately, over the last few years, I think our nation has become more aware of the complexity of the causes of the etiology of substance use disorders. And we are thinking more in this kind of circles that I depict in this slide. So obviously, we are all different. We are individuals and we have our genes, but we interact with the environment, and we interact in many ways. I mean, we interact, first of all, with family and peers. That's probably our most important community, or our most important communities as we move through life. But we are also conditioned by the neighborhoods and the communities in which our lives take place. So even our families do not completely control the way we develop. And then, of course, we are also embedded in our laws and culture. So on the one hand, these are sources of the etiology or the modeling of our personality and the etiology of substance use disorders. But on the positive side, all these levels provide us with potential levers or places where we can develop interventions, both for prevention and eventually for treatment when prevention is not enough. I like this slide because I think it's very schematic and gives these concentric circles, but we can also go through a little bit of more of a complex level and think about the multiple risk factors that have been identified for substance use disorders over the years. And what I present in this somewhat complicated slide is how we can place risk factors sort of in tiers. And so this is in a way a cascading model of substance use disorders. So you can see that early in life we are influenced by our family history. We are influenced by experiences that we may have in childhood, such as childhood maltreatment, childhood sex abuse. As I was mentioning, of the importance of the family, if our families live in a disturbed environment, or if there's parental loss, either through death of the parents or potential separation or divorce. Those are risk factors that are going to cascade into the next year, which would be early childhood. And so in early childhood, we may see development of impulsivity, development of low self-esteem, early onset anxiety, early onset substance use. And then you can see as the model goes forward that in adolescence, low educational achievement, potentially a history of trauma, certainly psychiatric comorbidity with anxiety, depression, ADHD, and other disorders. And so I think this model, even though initially it looks complicated with all these many boxes, you can see that in reality is fairly simple. We have a series of risk factors that interact with each other, both horizontally, if you will, at the same time tier, but also, as I was saying before, cascade forward as we develop. And so by combining all these risk factors, we can, on the one hand, understand or limit, if you will, to relatively small number of risk factors, but also understand the diversity of the individuals that we see. And I like to think of this in a way as cooking. You know, we have different ingredients and we are able to bake different foods. Or also, if you want to be more sort of scientific, sort of the atoms in the periodic chemical table, no, where you can combine different elements of the table and create an infinite number of materials. So by combining all these risk factors, we can understand how different people have different pathways towards the etiology, so toward the common pathway of substance use disorders, but at the same time, we as individuals are different. In identifying these risk factors, that gives us ideas about how we can intervene in terms of prevention. So for instance, we can identify knowing who has a family history of substance use disorders, who may be at elevated risk and might be a candidate for indicated prevention. We can also intervene preventing sexual maltreatment, childhood maltreatment, and specifically childhood sexual abuse. We can also treat early onset psychiatric disorders such as anxiety, ADHD, depression. We can also prevent trauma. So there are many ways in which we can intervene to prevent substance use. And one of the benefits also of intervening at these early tiers is that, as we all know, there's a fair amount of comorbidity with other psychiatric disorders. So by intervening over these general risk factors, not only we will benefit the population by preventing substance use disorders, but potentially avoiding or decreasing the risk of other adverse outcomes. And then I also wanted to talk briefly about the course of disorders. So this, in a way, I don't know if it's a mirror image or a complement of the slide I put about reaching treatment, but here you can see that eventually most people achieve remission. So if you look at, I mean, this graph is similar to the other one. On the vertical axis, you have the probability of remitting, and one would be 100%. And on the horizontal axis, you can see time to remission. So eventually, I mean, you can see that these graphs, many of them reach one. So eventually, the vast majority of people reach remission. But as I was mentioning, in regards to the slide on treatment, you can see, if you look at the horizontal axis, that for many people, it's going to take more than 10 years to achieve remission. So again, if you think about any other disorder in which we would wait 10 or 15 or 20 years for people with hypertension and diabetes, not to mention, let's say, a broken leg. I mean, if somebody broke their leg and it took like 10 or 20 years for that leg to get healed, I mean, it would be unacceptable, no? And yet we think of substance use disorder as something that eventually people will mature out of. Well, yes, eventually they will, but how much suffering, what are the consequences both I mean, in many levels, no biological level, the damage to our bodies, the damage in terms of psychological development, the damage in terms of relationship with others. So it is imperative to prevent that these disorders develop so that we can develop to the fullest of our possibilities. Then another aspect that it's important to think of in terms of the course of disorders is that even though individuals may achieve remission, there's also always a risk of relapse. Here I just put the example of smoking because it's so prevalent. And as you can see, it follows an exponential decay curve so that the risk of relapse is greater shortly after achieving remission. So in terms of how do we develop interventions and how we structure of intervention, it's important to think that because the risk is higher shortly after achieving remission, we probably want to put our prevention and treatment efforts towards the beginning of when people achieve remission. As people, and I mean, again, smoking, I think not only the epidemiology shows that, I think probably our clinical experience and our personal experience of people who have quit smoking or have reached abstinence of other substances is that the longer they stay abstinent, the less likely is that they're going to relapse. At the same time, as you can see, the probability of relapse never becomes zero. So we always have to be vigilant and provide support and help to those who need it. And it also sort of reinforces the idea of thinking about substance use disorders as chronic disorders. So many years ago, when I was started training, I think many people thought about substance use disorders as episodic disorder. Treated the episode or the crisis, that would be enough. But I think at this point, our knowledge really very clearly indicates that these are chronic disorders. And so we have to focus on prevention, or primary prevention if possible. But for people who develop the disorder, we have to develop interventions that would prevent relapse. So this also leads me towards the end of the first part of the presentation. What do we know about intervention efficacy? And I think over the last probably 2 decades, we've developed a number of interventions that show that can prevent or at least decrease the risk of developing substance use and substance use disorders. I'm going to just show 2 examples. One is PROSPER, and the other will be the Seattle Social Development Project. And both of them show a fair amount of efficacy. But I think one of the limitations, this one, I mean, this slide is focused on substance misuse, and this one is focused on broader outcomes like alcohol and other drugs. But I think one of the limitations of the interventions that we have, I mean, it's a limitation by design, is that they have been focused on younger individuals. And that's certainly appropriate. That was the way to start, in a way, the field of prevention. But as we know, and I think has become more evident with the opioid crisis, many individuals need start using drugs later on. So we need to develop interventions not only for younger individuals, but really for the whole range of populations. And also importantly, we need to develop interventions that have a general effect, but are also, or that we can also tailor to specific populations. I think it's become clear that, I mean, it's clear that all of us are different, but the specific populations may need a specific tailoring. So let me move to the second part of the presentation, which will focus on what is that we need to know. So some areas of opportunity that I see, as I was mentioning before. So we know a fair amount about interventions for children and adolescents, and I mean, there's still room to learn more there, but we need to generalize our knowledge about efficacy and effectiveness research, both in the initiation and the progression of care. And I see that the young adults would be certainly an area in which we want to really learn more. So to me, that's an area of opportunity. We also want to put more emphasis. I think we know a little bit about harm reduction, but again, I think over the last probably 3 or 4 or 5 years, we have all become more aware of the importance of harm reduction, even though primary prevention is certainly the ideal, the gold standard. If we can achieve that, it is inevitable that some people will engage in substance use and develop substance use disorders. So developing interventions and testing them and showing that harm reduction strategies are useful is something that is of great interest, I think, for the community and certainly for many of us who work on research. We have also increased our emphasis on health equity. We cannot continue to really focus the interventions only on a specific group of the population. We need to help all of us, and certainly help more those who are in most need. So to the extent that certain populations or certain communities have been affected or are affected by substance use disorders to a greater extent or with greater intensity than the general population, we really want to help those who are in most need to really prevent substance use and also remedy the problems that substance use has associated. And we also need to work not only developing new interventions, but in implementation and dissemination. So, I mean, one example I often think of is if we develop toys that were wonderful toys, fantastic toys, but we were not able to sell them to anybody and kids didn't want to play with these toys, how useful would that be? Well, it's not very different from what we're doing. If we are developing interventions that are very cool, that are very sophisticated, but nobody wants to implement them, then we're not really achieving our goal. We're not really achieving prevention. So when I think about prevention research, I think not only what would be sort of ingenious, what would be sort of intellectually appealing, but how can we really do something that will help our populations? How can we do something that will help the people who live around us and the people that we love? And then I guess as a complement to implementation, we also want to get more knowledge about fundamental science. What are the underpinnings of the interventions that are effective? Because by understanding what is effective, by understanding the components of the efficacy of interventions, we can develop both better interventions, but also make them more applicable and more easy to implement. And this sort of fundamental science can be at different levels. So, for instance, at NIH, we are funding, as you will know, the ABCD study, the Adolescent Brain Cognitive Development Study. So that's going to give us fundamental knowledge about the brain and the development of the brain and how the environmental influences and genetic influences converge to influence the development of the brain. And that will give us some clues for interventions. But it could be also at other levels. So it could be a better understanding of the psychological mechanisms that lead people to use drugs. And so by understanding what are the sort of the active components of the interventions that we have developed, then we can refine the interventions, but also adapt it to different populations. So obviously there will be different interventions. Maybe the basis will be the same or the general idea will be the same, but obviously we need to adapt the interventions. They're not going to be the same for kids in grammar school as for people in high school, as for young adults, as for mature adults. No, so and also it's not the same for let's say the general population as for a specific, as you have probably guessed by my name and ancestry, I'm Hispanic, so it's not going to be the same for the general population as maybe for a Latino population or maybe for an African American population. We may also need to make adaptations for women or women in specific stages of their lives. So by understanding the fundamental mechanism, we can develop better interventions, but as I was saying, even respecting the general principles, adapting to the needs of each population. So I think that's a very, very important area of opportunity. Some of the sample questions that I wanted to bring up today, and these are again just sample questions, so I'm not saying that these are the only questions. As I was showing in the slide before, there are many areas in which I think we need research, and we're not only research, I mean, really also implementation and better communication with people who are in charge of prevention delivery and not only prevention science. But again, some of the sample questions would be, okay, we have developed programs or we have developed interventions. What is that we need to do to really to really bring these interventions to scale? So one of the things that I think is frustrating for many of us is that we have these fantastic tools, but then once the research ends, they sort of die, no, and they don't really get implemented at the scale. So to me, one of the things that we should do in this summit is have some kind of discussion of, okay, what is getting in the way of the interventions being adopted? Obviously, if they're not being adopted, is not is not the fault of the community. So what is that we as researchers or we as policymakers need to do to get the communities to adopt the interventions? Related to that, how do we engage the delivery systems? How do we engage the health systems, either private systems or public systems, to get more interested in prevention, and again to sort of work out the kinks? How do we get the systems to say, yes, this is what we want to do, yes, this is going to be good for our community, yes, this is going to be good for the individuals that are part of our communities are under our responsibility. And from the point of view of research, from the point of view of NIDA, and I would imagine other research agencies, we want to know, okay, what is that we need to do? How do we modify the research? Or at the same time, from the researcher point of view, what kind of research can we do that would help us better understand what is that we need to modify? What is that would make it more appealing for the health systems to deliver these interventions? And one of the things maybe that is, I don't think is the only thing we need to do, but maybe one of the things that we need to do is better understand the economic impact of our interventions so that we can make a better business case. So, I mean, I think we need to provide prevention because that's the right thing to do. But as an additional argument, what is the economic argument? What is the business case that we can make to our communities so that people become more interested in these interventions? Now, of course, one of the issues with prevention is what people call the wrong pocket problem, so that maybe the agencies or the systems that invest in prevention don't reap necessarily all the benefits. And so there's a little bit of lower incentive to invest in prevention because you're not going to directly get the benefits. But again, I think to the extent that we can raise awareness in the community of the multiple benefits of prevention, hopefully we can motivate policymakers and decision makers to get more interested in supporting prevention. We also want to think in terms of what systems we want to use for the delivery of our interventions, and so tailor the interventions to the systems. And you can see that there are different systems: policy, education, healthcare. So tailor the interventions to that aspect. Then here, this is the second part where I wanted to make you angry. So one of the difficulties we see in translating prevention science to interventions is limited funding. So I think from the research point of view, it's important to look at partnerships. And so when we are developing interventions, it's important to see who is going to pay for the intervention once the research ends. And so there are many possibilities. One would be through Child and Family Services, through HRSA, SAMHSA, the Department of Justice. So it's important to be creative, and from the beginning, when we are developing interventions, see who is going to be the end user, or at least who is going to be the end payer, so that the intervention is tailored to the needs, to the evidentiary needs and the legal constraints that these agencies have. And also from the point of view of the other agencies, it's important to engage in a dialogue with the researchers so that the research is developed in a way that is going to meet the needs, as I said, of the consumers, the end users, both from the point of view of prevention, but also the point of view of who is going to make the payment. I think it's also important in terms of both research, but also implementation, to have a conceptual model of innovation. The traditional innovation model, as you know, is this idea that there are very, very smart people who generate the ideas and then impose these ideas top down and hope that eventually people will see the light and implement the ideas. I think that's the wrong model for implementation. And I think a much more productive way is what the National Academy of Medicine calls the learning healthcare system. And so it's really a cycle where the community and the people who are delivering the service generate questions, and then the researchers come up with ways in collaboration with the community to provide those services. Now, the learning healthcare system has been applied mostly to treatment, but my view is that we should engage in a similar dynamic in terms of prevention, so that the community tells us, well, these are the needs that we have in terms of prevention, And then the researchers engaging with the community can try to find ways. And again, as you can see, this is a cycle. So the community would come up with a need, the researchers would come up with some ways of solving the problem. It will not be completely solved, so that will generate more questions from the community. And little by little, as we do in many things in life, we will perfect and refine what we need, and hopefully we would come up with better interventions that are both more effective and more implementable and more sustainable. I want to end the talk by reminding you that treatment is not enough. And as I said at the beginning, I hope that I have made you a little bit anxious and a little bit angry, but also hopefully I have inspired you a little bit with some ideas about how much we have achieved over the last few decades, but also how much is left to be done. And I have energized you so that throughout the summit, and more importantly, after the summit, we can all continue together to develop more effective, more implementable, and better interventions for our communities. And with that, I want to thank you. I think we hopefully have like 2 or 3 minutes for questions, so probably I will only be able to answer 1 or 2 today. But my email is on the internet, and I will be happy to receive your feedback, comments, and suggestions so that, again, we all together can improve the health of our nation. Thanks very much.
Thank you, Dr. Blanco, for that wonderful presentation. We actually did have a couple questions come in. Are you agreeable to answer in those for us?
I'll do my best. If I don't have the answer, I'll think about it and get back to you later on, but go ahead.
All right, the first question is, I appreciate the guidance around where we want or need research. Who is currently doing any of the research, and where and to whom can we advocate for more of this type of work?
So, I mean, there are several agencies that fund research. NIDA is certainly probably the most important research agency, but other agencies such as CDC, sometimes SAMHSA, and other fund research. What I would recommend is that you go to our webpage. If you Google NIDA or the National Institute on Drug Abuse, you will find the webpage, and from there you can see the different type of research that we do. I mean, our division funds about between $500 million and $1 billion per year in research. So we do research on many domains, but also on the webpage, you will find the names of the program officers that can guide you on a specific topics. Now, the second question, as a federal employee, we are not allowed to lobby, but as private citizens, if any of you think that something should be done, either provide more funds for prevention or less funds for prevention, you can talk through, I guess, a non-private organization or talk to your elected representatives. And I think that's the way democracy works. Each person sort of voices their view, and I think that would be the way to go, to advocate for what you think needs to be done.
Thank you, Dr. Blanco. Another question's come in that I'm going to parse out because I think part of it really is directed towards one of our presenters later on who can give some guidance around integration of various strategies for communication. But one piece of this I'd like to direct specifically to you, and it's regarding messaging for harm reduction. This is something that's come in over and over again in some of our TA requests, along with messaging around preventing onset of use. How do you all approach that in NIDA from a research lens and studying in light of the nature of fentanyl and the substances that are out there today, right? And maybe some of their unique nuances with the outcomes of overdoses, the potency. How does NIDA approach interventions and studying that type of messaging, specifically for harm reduction, and then possibly integrating that? Are there any integrated approach with messaging for preventing onset of use while also educating about harm reduction? Anything being studied in that realm that you could speak to, or how NIDA is approaching that?
Yeah, so we are intervening sort of at 2 levels. I mean, one is we are a research agency, so for us it's very important to rely on the evidence, and so we need to distinguish what is known from what is that we think it's important to know. And so we find the studies to examine, let's say, I mean, certain things like syringe exchange programs, I think at this point are well established. I think other topics like supervised injection sites are a little bit less known. So the first thing that we do from the NIDA point of view is fund research to establish the evidence, because we want to be very clear that what the information that we provide is unbiased and not politicized and is based on the facts. But the second part of the question which you raised, and it's also very important, is that even when you know the facts, you need to know how to approach how to deliver the message. And I think as scientists, we are not often as great as we should be. So I think we rely on saying, well, the knowledge is here and people should see the light just because the knowledge is here. And I think you are very appropriately, or the person who raised the question, how do we communicate with different audiences? And I think that COVID-19 has been a big lesson about how even when you have the science, it's difficult to reach certain communities. So we are funding a little bit of research on communication, but it is certainly a big challenge for us. I mean, not only at NIDA, again, for many scientists, how do we reach different communities that, for a number of reasons, either historical reasons, ideological reasons, are not necessarily trusting science and scientists. So I think it's a great question, and I'm curious to see what I mean, you said that you have other presenters who are going to talk about that, so I'm looking forward to see what I can learn from them, because I know a fair amount, but other people know much more than me, so I'm always willing to learn about what other people are doing.
Yeah, thank you for your response. I think that I think we all just need to understand a little bit better, because it's a new thing, right? Relatively new over the last 10 years in terms of harm reduction for fentanyl overdoses specifically. And we are excited to see what NIDA does to approach this and studying the messaging for effectiveness and maybe providing some guidance for us as we move forward with some of those outcomes. Another question that came in related to genetics. The genetic component of substance use disorders seems to be about 50% of the problem. Are you familiar with reward deficiency syndrome, and could being tested for reward deficiency syndrome help in preventing substance use disorders?
Yeah, I mean, the person who asked the question is correct. There's 50% of the variance in risk for substance use disorders is genetic. What I think is more difficult to know is, because as we all know, substance use and substance use disorders are polygenic behaviors, and so it's difficult to know what gene exactly is the responsible for the specific behavior. No, I think from a theoretical point of view, yes, acting on reward deficiency syndrome could be effective, but one thing is to have the idea, a different thing is to really carry it out. That's why, and intervening on genetics is for the moment quite difficult in humans. With CRISPR-Cas and other technologies, we might eventually be able to do it. I think at this point, I think it's easier to intervene on the kind of risk factors that I presented in one of my early slides. So I think we have interventions to prevent childhood maltreatment. We have certainly very good treatments for psychiatric comorbidity. The community, I think, has become also more important in preventing trauma. So without discounting the idea of acting over deficiency syndrome, again, I think in terms of prevention, there are other behavioral targets that might be at this stage of the science easier to intervene on. But I wanted to go back to the previous question, because I think it was the communication. So we as scientists, as I said, are not that great on communicating, but I think it's very important for the community to communicate with us. So we have a responsibility to communicate, but we need to hear from you what's important. I mean, that's why I put this idea of the learning healthcare system, to hear from the community, to hear from you what's important. We have our own ideas about what's important, but we are a minority. We really need to know from the community, I mean, like harm reduction, this is important for us. Social determinants of health, this is important for us now, so that we can conduct the science and fund the science that responds to the needs of the communities and not only to the curiosity of the scientists. So communication has to go both ways. And I encourage you to be critical of, I mean, not only critical of us, really tell us what is that you need so that we can fund the science to satisfy your needs and solve the problems that you have.
Well, thank you for opening that door, Dr. Blanco. We actually have Jean Casey from NIDA sits on our HIDA Prevention Communications Council, and we are constantly feeding her with what's coming in from our technical assistance requests. So I'm sure she's going to carry that forward to you, and I will encourage her to do that as well. Dr. Blanco, we sincerely want to thank you on behalf of the ADAPT team and the National HIDA program. Want to thank you for joining us today. You did a fabulous job last year and again this year, and we always appreciate having you join us in the summit.
You are the stars of the summit. I'm just a small contributor, so thanks for inviting me.
At this time, we are going to log off of this session. You should have an evaluation pop up this time if you are interested in getting a certificate and continuing education credits. We will join you at the next session, which is our morning keynote speaker, Dan Heath. He wrote the book Upstream, and we're excited to see you over there. Join us now.